My name is Jonathan Lee. I've been here for about 9 years at the Farley Center, so welcome to the Williamsburg Place campus. This is actually the very first time that I've ever spoken for the Williamsburg Place lecture series. so that's after 9 years of being here. So I guess I finally either grown up, graduated, or I don't know, I think Eric Rose needed somebody to fill in for this month. So you guys, thank you so much for being here on this beautiful Friday morning while it's raining outside. I think it does somewhat reflect the state of the opioid crisis, which is at times quite gloomy, but there is some positive things that we're seeing as far as the turn of the tide. And then looking at this as a wicked problem. Just to get a feel of who's in the audience today, even though I know some of you already from either working together or in other settings, could we just have a raise of hands of people who either professionally or personally have been impacted by the opioid crisis in any way? So I'm thinking like almost everybody, probably like 90-some% is my straw poll guess. And then of the folks who are here, I think probably the majority of you are healthcare providers. How many of you identify as either being in the counseling, therapy, or social work field, just to get a general idea? How many more in the nursing profession, medical field, pharmacy field? Okay. And any other providers that are out there that I missed? Assisted living community? Okay, great. And certainly we are seeing more and more of the opioid crisis affecting the older adults too. All right, so yes, sir?
I don't fit in any, I'm the wrong peg in the square hole. I'm in the Justice Department.
Justice Department, yes. So certainly law enforcement, Justice Department is affected. Yes, ma'am? Yes, peers in recovery, absolutely. Is it called With Peers? Yes. Okay. All right, awesome. So we're going to get started. So as far as the objectives for my talk, one is to define what is a wicked problem. Number two is to define the state of this opioid crisis. And then we're going to look at it from the perspective of the Virginia Board of Medicine. So we have the regulations, which you may ask, like, why are we talking about that? It's because it impacts not only our patients, clients, but also ourselves too. About the Virginia Prescription Monitoring Program, they have a new platform that's called NarxCare, which I think a lot of providers are asking about, so we're going to go over that together. We're going to have an overview of diagnosis and management of addiction, so it won't be comprehensive, but it'll give you an idea. And then we're going to discuss some big picture strategies for how we can attack the opioid crisis from different ways. And then towards the latter half of this talk, we're going to do a case discussion so that you can participate a little bit more. The first part will be a little bit more lecture-based. So just anybody out in the crowd, does anybody know what a wicked problem is? Have you ever heard of what that is? Boston Red Sox, so the wicked problem. Okay, well, I mean, I think that's good. There's a lot of different concepts of what a wicked problem is as far as untangling a wicked problem. So this is based on Professor Jim Over. So he's at the Mason School of Business at the College of William & Mary. So Jim Over, he teaches, and this is based on a lot of other research that preceded him, that a wicked problem is a complex system with components that interact in poorly understood and unpredictable ways. So we're trying to figure out a problem. We're not quite sure which way it's going to turn. Interventions into the system can produce downstream consequences that cannot be known in advance and cannot be undone at times. So not only is it unpredictable, but at times after the downstream consequences have occurred, it's really hard to undo it. And then changing one element of the system can actually impact the dynamics of the entire system. So it's almost like you're trying to contain and control chaos, which is a bit of a issue that we have with the opiate overdose crisis, often referred to as the fatal drug overdose crisis, as well as addiction as a whole. So these are some of the things that we're going to look at, is that in 1980, the New England Journal of Medicine, which is one of the more respected, highly cited journals by the medical and other communities out there, is that there came out a one-paragraph letter that was published. And based on that letter, there's been this myth over decades, unfortunately, that the risk of addiction was low when opioids were prescribed for chronic pain based on this one-paragraph letter. It's actually one of the most highly cited letters that I can think of as far as in the New England Journal of Medicine. So people kept on going back to that, saying that, oh, it's safe. This is a population of patients that they've observed. It was not a randomized controlled trial. These are academics who were trying to provide their observations in a letter form, but not in a controlled study form. So by 1996, just to kind of give you the story a little bit further on, the American Pain Society, they decided to introduce pain as the 5th vital sign, which if you think about it, that's also a wicked problem to itself. I mean, how can you measure pain as a vital sign? If you're going into the ER, going for your annual checkup, blood pressure, pulse rate, respiratory rate, pulse oximetry, weight, height, those are measurable things that you can actually have an objective tool. But pain, as of now, there's a lot of different ways to measure pain, different scales, but there is no, I would say, reliable, validated form of a 5th vital sign that relates to pain itself. There's a lot of sad faces, smiley faces, numbers 1 through 10, but it becomes a problem to itself. Yes, you have a question back there.
I have to contain myself. I teach drugs in college.
You teach what? Sorry.
Drugs in our culture.
Drugs in your culture.
Yeah, and I teach about the FDA and things like that. Is it possible that people really thought they were non-addictive? Because I knew as a teenager being prescribed them for migraines. Yeah, they're addictive. I mean, I don't understand how they could have gotten away with that.
The opioids?
Yes.
Right, and we'll talk more about that. I think you're right that there's that perception, and we'll get into the kind of the cultural as well as even some of the pharmaceutical marketing related things. So we'll get to that. So as far as other things that added to this problem is that now that the 5th vital sign was pain, of course, we wanted to be able to monitor it. So the Joint Commission on Accreditation of Healthcare Organizations, they decided that all organizations that were going to be accredited needed to evaluate for pain scores, and not only would their surveys be impacted by whether or not they're doing a good job of making pain as close to 0 as possible, but maybe reimbursement from insurance companies would also be impacted too. So there's starting to be a financial gain to it as well. So unfortunately, as the story tells, and as I guess as you were alluding to, is that in 2007, Purdue and 3 executives pleaded guilty to misbranding OxyContin and agreed to pay $634.5 million. Sounds like a lot of money, but when you look further down, they've been making billions of dollars. So that's actually just a very small portion of it. And as if you go onto the New York Times and some other editorials out there, even though this was settled, the issue with this is that there wasn't a lot of further investigation or opening up to the public media about the dangers of opioids, particularly as people were getting addicted to it. So in 2014, by then, despite the fact that Purdue had already suffered a lawsuit, greater than 240 million prescriptions had been written for prescription opioids. This is based on the U.S. Department of Health and Human Services. And then by 2015, according to the Annals of Internal Medicine, there were at least 92 million people in the U.S. that were prescribed an opioid. And if you think about this in the big picture, there's about 80% of all the prescription pharmaceutical opioids are prescribed in the United States. So of all these prescriptions and all the opioids that are actually being prescribed, most of it's in the U.S. So that's another wicked problem to that. So if we look a bit further downstream, so in 2017, just a couple years ago, Purdue continued to make a lot of revenue from OxyContin. And by 2018, the New York State, as well as 26 other U.S. states, Puerto Rico included, they decided to formally sue Purdue Pharma. There's an ongoing lawsuit with that currently. So it was for widespread fraud and deception in the marketing of opioids, contributing to a nationwide epidemic that has killed thousands, certainly getting close to millions. Misleading doctors and patients by overstating the ability of opioids to improve bodily function while downplaying the risk of addiction. So certainly there's a lot of things at play. It's not just kind of one particular stakeholder or one particular group of people that's at fault. It's a lot of different things. So what is misuse or non-medical use of a prescription? This is according to the National Institute of Drug Abuse, or NIDA. So for those of you who are either aware of medication abuse or whatnot, it's taking it in a manner other than prescribed Oftentimes, it could be more than prescribed, or let's say they crush it up and snort it. Other ways of taking the drug. One of the most common ways of somebody first getting opioids is actually from somebody else. So it's from somebody else's prescription. Taking a medication to feel euphoric for an effect other than what it was intended for. Sometimes it is, they were taking for what it was intended for, but they also still get that euphoric feeling too. And then, not surprisingly, because as we've looked at the opioid drug overdose epidemic, is that more and more people, even if they are, quote, heroin users, they often have started first off by using these prescription opioids, which are supposed to be controlled and regulated. So looking at this from the CDC perspective, so from 1999 to 2016, so we're talking about more than 500,000, like not quite 1 million people died from drug overdoses. And we do have to remember that these fatal drug overdoses oftentimes include not only opioids. Oftentimes, they also have concurrent use of other sedatives, such as benzodiazepines, muscle relaxants, quote, sleep aids, such as drugs like Ambien. They often on other substances, too. They could be on alcohol, and they could even be on medicines that are being used for treatment of other underlying conditions, whether that be for co-occurring mood disorders or also even for addiction itself. Because it's not uncommon that sometimes people may already have some Suboxone, methadone that they're already taking or they're getting off from the streets. If they combine it with all these other substances, their chances of dying are extremely high. So we're looking at, again, in 2016 alone, there were over 64,000 drug deaths. And again, two-thirds of this could be attributed to opioids, but it's not the only thing. And again, this is 5 times higher than compared to 1999. This statistic changes kind of day by day, but we could say over 100 people die every day as a result of opioid drug-related overdose. So this is another alarming statistic. So the Journal of American Medical Association, they published this in 2017 about the contribution of opioid-involved poisoning to the change in life expectancy. So for decades and decades, particularly in the United States, that being one of the leaders in the world, is that our life expectancy has either stayed about the same or has actually increased from generation to generation. But for the first time in this particular study, it's saying that drug poisoning mortality more than doubled, again, as we saw in the last 15 years preceding the study, and that poisoning mortality involving opioids more than tripled, which somewhat reflects the previous CDC statistics as well. And then reduced life expectancy for the first time was observed in non-Hispanic white individuals in the U.S. during that period of time. So again, this is huge because they're saying that it's not just, it's unexpected, but also we think that the opioids have contributed to this change. So we're going to take a look at the Commonwealth of Virginia and as far as how the opioid crisis has affected us here. These statistics may be just a little bit outdated, but I think overall they kind of give you the big picture of what's going on. So if we look at our young high schoolers, about 1 out of 6 high schoolers have misused prescription drugs in their lifetime. I mean, that's quite alarming. I have actually 3 children myself, so I'm just like thinking like eventually as they head into high school, like what are their risks? I mean, that's 3, and if I had 3 more, which I would never do. So if I had 6 kids, I suppose one of the 6 would have a pretty high statistic of being introduced to opioids. That's kind of crazy. If you think about it, in a high school setting, if everybody, not everybody, but if a lot of people are trying out drugs or substances, so 1 out of 56 of them are going to be trying out heroin during the time that they're in high school. That's also a very alarming statistic. And this is not a nationwide statistic. We're looking at Virginia as a whole. One of my actually patients who I presented this talk to just last week, they were saying that in the area that they're in, I think their statistics is about 1 in 35 of high schoolers are actually getting to the point of using not just opioids, but also heroin. In heroin, as the potency has increased over time, there are people who actually start sniffing it, snorting it. They still get high and they can die from it rather than injecting it. So that's part of the prevalence of why heroin is becoming more and more popular and sometimes more accessible as well as cheaper than the pharmaceutical grade opioids. So if you look at time frame, about every 12 hours, a Virginian dies from an opioid drug overdose. Over every 2 hours, a Virginian is arrested for an opioid-related crime. And certainly our goal is to treat, not focusing on just arresting, but certainly there has to be some consequences for certain things so that people can get stabilized for treatment as well. So there were 4,000 or so administrations of Narcan, which, I mean, in some ways that's a good thing because we've been trying to get naloxone or Narcan out to our first responders. But the sad thing is that it's been required to be used because of all these drug overdoses. And then over $500 million have been used annually just in Virginia alone related to the opiate overdose epidemic. So yes, sir, go ahead.
I have a question about that Narcan. Could you give a little information about that?
Sure, I'll give you a very short information. So Narcan or naloxone, it's a short-acting opiate blocker or opiate antagonist. It comes in different formulations. It can go through the nose. It can actually be given intramuscularly, intravenously, or IV. There's different formulations of it. So when it's administered, the thought is that it can reverse an opiate drug overdose. It's not going to reverse it if somebody is taking a lot of benzos. So there's other substances like flumazenil that's used to reverse sedative or benzo withdrawal or benzo overdose. But as far as for opiate overdose, the concept is that Narcan can help somebody to start breathing again, and then so that we can revive them. All right. So I'm going to move on to the Virginia Board of Medicine regulations. So this is from the perspective of Dr. Harp. He's their current executive director, and he was willing to share his slides with me. So if we look at the Commonwealth, in 2002, there was a strong concern by the Board of Medicine that there were just all these overdose deaths and what's going on. By 2003, the legislature started to take notice, and they actually gave the board a simple negligence standard for taking action for providers who were not paying attention or not prescribing appropriately. In 2003, the legislature established the prescription monitoring program. So that was really at the infancy of this PMP or database that's used for tracking controlled substances. In 2004, the board decided to adopt what's called the Federation of State Medical Board model policy on the use of controlled substances in the treatment of pain. Certainly at that time, there was still a lot of discussion as to what was appropriate, what was not. So in 2006, so this is the Board of Medicine in conjunction with the Prescription Monitoring Program. So with the support of the Medical Society of Virginia, they started to actually go around the state giving presentations on management of things related to pain and proper prescribing of opioids. That was their initiative, just to do educational talks. While all that was going on, as we learned earlier in 2007, Purdue Pharma, again, they pleaded guilty for the misbranding of OxyContin. And in 2007, kind of the same time frame, you could see how they, quote, contributed this amount of money. In the Commonwealth, there was about $20 million that went into getting this PMP started, or at least getting it even more robust. And then the Board of Medicine developed regulations on pain management and prescribing in 2007. Did you have a question related to this slide?
Yeah. What was the misbranding?
Oh, I think the misbranding effectively was saying that based on their formulation, the risk for abuse/addiction was very low because of the way that the medication worked. Yes, sir?
Yeah, the first thing there, the misbranding with OxyContin, can you give a...
To describe that some more?
Yeah.
So effectively, when they created this new product, so the generic name for OxyContin is oxycodone. So oxycodone comes in many different formulations. There's short-acting, long-acting, and then as pharmaceutical companies tried to make a safe formulation of this drug, they branded it as effectively as a medication that's safe and effective for treatment of pain, whether that be acute pain or chronic pain. So I think the misbranding part had to do with the safety part of it. Sure, these are good questions. So in 2009, the executive branch requested that the board withdraw its previous regulations. They felt like whatever they were doing wasn't quite working out. So then they started to take a look again at these overdose steps that again continue to climb, and we're going to take a look at those numbers soon. In 2013, they again went back to the Federation of the State Medical Board to look at policy for what do we do about opioid, pain, analgesics. In 2014, for the first time, the governor of the time with the attorney general, they became concerned enough about the crisis that decided to call it a actual emergency. So as a result of that, they formed the Governor's Task Force on Prescription Drug and Heroin Abuse, which I think it really should include opioid abuse, which is everything. And then through that task force, he was given some recommendations between 2015 and on. And that's kind of where we get to where the state of things as we get to this 2019 is in 2016, the General Assembly, they passed a law that authorized the Board of Medicine to require that all prescribers, providers in the Commonwealth of Virginia, they had to do at least 2 hours of continuing education on controlled substances in each biennium. So it was no longer just a voluntary education or just kind of, if you happen to do this. So we have to do this 2-hour requirement for those of us who are able to prescribe to learn about pain management, responsible prescribing, as well as diagnosis and management of addiction, which for me, because I'm an addiction specialist, that to me is the most important part. And I think this part is certainly very, very important too. But without the whole thing, people are just going to not know what to do, like once they get people addicted to drugs and trying to get them off the opioids. So for those of you who are interested in doing some additional reading or actually would like to get the CMEs, the Board of Medicine, they created what they call a 2-hour pack or package where you can effectively read about their regulations on opioids and buprenorphine. There's a frequently asked questions about these substances. There's actually an excellent Stanford University course that you can take online for free, and you can learn about how to taper opiates off of chronic opioid therapy. Even if you're not the one who's doing it, it's often nice to have some knowledge if you're collaborating with a provider who's doing that or with a patient who's going through that process. And then the other part of this package is that people can go online and watch a 7-minute video about NARCS care. So we're going to get to that very soon. So I think this is going to allude a little bit to the concept that in the U.S. as well as in many other developed nations that we often have first world problems. I think I had a friend who her mother, her complaint was that she couldn't find her car because she couldn't remember which car she drove that day. So I mean, that's like a first world problem. Some people don't have those worries because they don't have enough water or running water to get to. So one of the issues that we have is that we do have a lot of different medications with a lot of different indications for the entire world. But these are FDA-approved medications. So this is just an example of generational issues that we see. So antibiotics, amoxicillin, it's like we're trying to work on, quote, a drug-free America, trying to be healthy and whatnot. We have a lot of youngsters who do suffer truly from ADHD and other, issues that they need help with. But then there's also a lot of competition, performance enhancing, whether that be Ritalin, and also people who are trying to control their body weight, body image. So we just need to keep in mind that not all medications, have the exact outcome that we expect. So that's another wicked problem to itself. So there's people who are trying to stay awake. Maybe they're staying up all night playing video games. So gaming addiction is actually a truly real thing, which the ICD-10 as well as DSM is looking very closely at. Prozac, which again, some people do need medications for treatment of depression, anxiety disorders. On the other hand, sometimes there's that culture that everybody should be on a medication, and that's certainly not true. I guess we all get a little bit of heartburn as we, over time. So it's talking about the Zantac or proton pump inhibitor, acid reflux reducers. And then unfortunately, as we get older and older, then this is part of when people get into assisted living facilities, nursing homes. It's really hard for some reason for people to stop a medication. It seems to be very easy for prescribers to continue to add on and on and on. So polypharmacy is a huge problem for anybody, but particularly in the older adult generation. So that's just a reflection of the problems that we see besides the opioids. Yes?
One of the concerns that I see, and I've seen it several times in minutes and documentaries like that, where they have these pill mills, even in the face of these opioid crisis that's going on right now, that in Florida, they think they're prescribing, they've arrested some, but they're still able to pop up and grow, where they're just really pumping a lot of opiates out into the community.
Yes, yeah, that is a huge concern. So you mentioned the pill mills and how that could be in any state, but you talked about Florida as an example. We certainly have a number of our patients who go out of state to get their substances of choice. Opioids included, so oftentimes they'll go to like the southwestern part of Virginia, or they'll go all the way to West Virginia, Tennessee. They'll cross state lines. And one of the good things about the prescription monitoring program is that they're doing their best to try to consolidate that data so that people can monitor that better. And law enforcement is actually able to access some of this data as well. So it's not a perfect solution, but there have been providers who have been sentenced as well as had legal consequences due to their prescribing behaviors. So the prescription monitoring program, so this is a resource for prescribers and pharmacists and for any designee of somebody who's a prescriber. So any of you, I think, potentially as a healthcare provider, if you work collaboratively with a prescriber, such as a physician, a nurse practitioner, a physician assistant, you can actually ask to be a designee and be able to have access to this database for your clients. Yes?
I was just wondering, are people able to access these online?
Oh, you mean like a patient on their own?
Yeah, oh yeah, I thought you were saying
So the prescription monitoring program, again, you have to have a login. So the actual PMP database requires somebody who's authorized to use it. But you, yeah, clever people can do a lot of things. So I would not be surprised. So you're right. So I think one of the things about a database that's available not only to people who are authorized is that security is important, cybersecurity. That isn't something that the PMP has communicated with me specifically about, but I think it is a concern. So that we want to make sure that that information is secure because it has a lot of confidential information in it. So these are Schedule 2 to 5 drugs, including they started monitoring gabapentin or Neurontin, which they started to see that people were misusing or abusing, and naloxone Narcan, which is the one that's used for rescue doses of opiate drug overdoses. So then again, we already talked about who's authorized to use it. Pharmacies are supposed to update this in real time. There often is a delay, and more recently it's been better, but sometimes the delay can be up to days or even more than a week before it's updated. Although there was one update recently where I had a patient who was in treatment, and for some reason somebody picked up their opioids. So we found that out from the pharmacy when we actually called. So yeah, that's something in itself is a problem. So PMP, it is interoperable. So the very cool thing for us who's able to use the database is that it not only looks at Commonwealth of Virginia, but expands beyond that for some of the interstates, and North Carolina being one of them as well. So it requires proactive monitoring. It helps them to look at not only the prescriber, but also the patient, and also looks for any signs of doctor shopping and how law enforcement may need to get involved in certain situations, such as with pill mills as an example. So the integrated PMP, they feel like it's been quite a game changer because for some facilities that have electronic medical records or electronic health records, it can actually be integrated into it so that you're not having to always, again, log in separately, but you can do it as part of your patient care. And then as you log in, you can look into a number of things. So one is to look at, is this patient opioid naive? Again, this is the data that we have is as good as it is. So they might be using opioids from somebody else. They might be getting opioids off the streets. But based on the controlled substance database, at least we can have an idea based on those prescriptions. Have they ever been on prescribed opioids before, based on what we know? And then the patient, have they been using other controlled substances in a frequency, like how long has it been? And we'll talk more about that. What sort of pattern are they using as far as getting prescriptions filled, at what pharmacies geographically, who are the prescribers who are providing it to that person? Are there multiple prescribers at the same time? And the risk of overdose, which is based on some of their algorithms, which we're going to talk about. So you get a list of prescriptions, and the way that they formulate it for the person who's using the database is to try to make it not only user-friendly, but also to make it so you can interpret some information from it. So as far as the 3 categories of substances that they monitor closely, it includes narcotics, which I would say that includes pretty much all the opioids that are prescribed. And that includes buprenorphine, Suboxone, methadone, some medicines that are also used for treatment of opiate addiction. Sedatives, as I mentioned, that is a huge category to itself. Stimulants, which includes things like Adderall, Vyvanse, Ritalin. So those are the 3 big categories of substances. whoever's looking at the database, they can see that there's going to be 3-digit numbers that are on the database. And the number represents, one part of it's the number of current prescriptions, so you don't have to like go down and count everything. And then the first 2 digits result from what they call multi-dimensional analysis of the prescription data. So that it can include not only the amount of medicines, the number of providers, the number of pharmacies, concomitant medications, that being like if they got the same drug at the same time, and overlapping scripts where they're filling one before they've run out of what should have been their 30-day supply, they've already filled another one, let's say from the ER or some other place. So it's supposed to provide all that data concurrently. So then based on their algorithm of what this is, they created what's called the NARC score. So the NARC score has effectively 2 tiers. One is either they're in a category where the actual drug itself is at a low dose, but they either have low risk behaviors versus higher risk behaviors. And then there's another tier where it's they're on high doses of certain substances, but they actually have either low risk versus high risk behaviors. So an example of somebody who's at a high dose with potentially low risk behavior would be a patient who's been treated for chronic pain for, let's say, 10 to 20 years. Their tolerance to opioids has increased over the last 2 decades. They've been taking their medications as prescribed. They have, let's say, because of their tolerance, they're on a high dose of whatever opioid they're being prescribed. So their morphine milligram equivalents can be quite high, but they may have had one prescriber the entire time, one pharmacy they've been going to the entire time. So then that would be considered a low-risk behavior, as far as you can see on the database. And then there's a distribution of these NARC scores, and this is kind of based on their statistics, that people who are generally over 500 are certainly at risk because the rest of the people are less than 200. And the overdose risk score, again, these 3 digits ranging from 0 to 999, that's another category of their formulation or algorithm where they looked at the higher the score, the more likely they are to die from an unintentional overdose death. Unfortunately, that's not going to be able to look at people who actually attempted to overdose on purpose. So there's that epidemic of fatal drug overdoses, but also the epidemic of the silent suicidal ideation attempts, which people may not know because they're already on a lot of substances. So again, they correlated to about greater than 5,000 overdose deaths based on these numbers, just statistically speaking, to say that this number is valid. You had a question?
People that have been prescribed opiates for chronic pain for 10, 20 years, what do they kind of eventually do when they build up such a tolerance they need really a fatal dose?
So you're saying that the actual dose itself might be fatal for somebody who's opioid naive. On the other hand, if they continue to escalate in their dose, they could die as well, because if they're taking that along with, if they have like other acute medical conditions, and they can be more susceptible.
Living longer with chronic pain, I'm wondering, because people have been on this for years, what are they doing?
Well, I mean, based on the guidelines from the Centers for Disease of Control, CDC, for prevention as well, is that their guidelines are to look at other options other than opioids. So there's non-pharmacological options, which a lot of it is actually counseling, therapy, physical therapy, acupuncture, meditation, mindfulness relaxation. There's so many things that we can do to help with management of chronic pain. So we're looking at non-medication options. And then if we are looking at medication options, to look at non-opioid options too. So I think that's kind of part of the education as we have more and more people who are learning about it, as well as patient education too. So you're welcome. Okay, so this is a test patient. So let's say if you were a designee, or if you're, let's say some doctors or providers will actually show you your prescription monitoring data, because they're going to show you, like, why am I doing this and why am I concerned? So they could pull the computer towards you and say, based on this, your narcotic score is this much, sedative score, stimulant score, this is the overdose risk score. So again, anything, the higher it is, particularly as it gets closer to over 500, the more likely somebody is to have issues with overdose, unintentional overdose deaths too. This is the area where effectively greater than any amount of morphine milligram equivalents, so there's different cutoffs, such as greater than 50 or greater than 100. There's more likely to be issues with unintentional overdoses. This is a list of, again, how prescriptions might be listed over time, and this is kind of like a timeline of when prescriptions overlap. And if you look at the summary here, you can look at the actual number of prescriptions, what cities people are going to. the actual fill date, which again is not perfect, but it does give me an idea of when somebody may have filled it, because they'll often come in and said, oh, I haven't taken the opioids for about 3 months, and then my question will be like, why did you fill it just yesterday before coming in? So they often will have other answers to that. So then some of them actually might be selling it as well, because they're trying to get money to do other things with it, or they may prefer to use heroin. So there's a lot of issues at hand. So you can see the quantity and where they fill it from, as well as the prescribers. So this is, again, just a pictorial. And then this is the additional resource that's provided to either the prescriber or the designee who's checking up on these things, is that we can find out who are like local providers who could actually take a further look at, is this an addiction problem versus other things, like how could that person get help for this issue. So based on the Virginia Prescription Monitoring Program, these are some positive trends. So if you look at it, the number of actual prescribed opioids have gradually declined over the last couple of years. They gave me data up until the first quarter of 2018. They said that as far as sedatives or tranquilizers, that's been pretty steady. That hasn't changed a whole lot, so that's something certainly we still need to take a look at closely. And then the line for the, I actually have two sets. So they distinguish tranquilizers from sedatives, so they're both steady. And then the stimulants are right in the middle here. It looks more like a purple dotted line. So that's been about the same too. So there is a positive trend, but on the other hand, there's still more work to be done. Yes.
Can you say anything about the morphine equivalent calculation?
I can do my best. So morphine milligram equivalence is based on this algorithm. So they try to associate or correlate, let's say, if somebody had so many milligrams of oxycodone, how many milligrams of morphine would it be? And that's just a conversion scale to try to make it easier to calculate. One of the issues with the morphine milligram equivalent is that it doesn't convert well for certain medications or drugs such as methadone. So methadone, the way that the medication works, pharmacodynamics and kinetics, is not going to equate into a morphine milligram equivalent directly. So it's not a perfect way of measuring things, and that's why they have like different scores to look at it too. So in the Virginia Board of Medicine, they have regulations that if a prescriber exceeds a certain morphine milligram of equivalence, they have to document and justify why they're doing that. And if it goes above another level, then they have to actually consider consulting with somebody else for help. So we kind of use it as a guide. Another question?
Yeah, so as far as the scores are concerned, our scores, is there any kind of standard protocol in place whereas if the number escalates to a certain level, the doctor is mandated maybe to offer or research some other alternatives like acupuncture or whatever have you?
Oh, that's an excellent idea. I don't think that they've gone to that part of it. What they have recommended, and it's part of the regulations, that if it's above a certain either morphine milligram equivalents, although NARC scores could be used too, then naloxone or Narcan has to be prescribed for that patient. Regardless of whether they have an abuse, addiction, or chronic pain issue, they need to be prescribed that medication. So it's a good question. So with Narcan is actually a standing order at all pharmacies in Virginia. The cost, insurance coverage can be variable, but if somebody needs Narcan, they can go to any pharmacy in the U.S. without a prescription. Just like if they had an underlying condition of diabetes, if they needed insulin, they can go to any pharmacy. Two questions? Yes.
In your experience, how diligent are physicians at running the PMP reports?
How diligent are they? Actually, when I get my PMP report about how I use PMP, they do like statistics on how do I compare to my peers. So the good news for me, because I work in an addiction treatment center, is that my prescribing of opioids is low compared to other peers in my category. I do use some opioids because it is used for treatments such as buprenorphine, Suboxone. But as far as prescribing high doses of opioids, I'm not in that category. They also have a comparison for like how often I use the PMP compared to my peers. So I think that I'm either on par just based on their statistics. So it's pretty close. But it's not to say that there are some providers who, because either they're so busy and then they feel like they don't have time to do it, that's part of why they need to designate somebody to do that. So if they're running a pain management clinic or anything where they're prescribing opioids, Oftentimes, they'll build it into their system where the nurse or some provider within their treatment team is actually querying the PMP before they actually meet with the physician provider or whoever. Yes, another question?
Yeah, what about physicians who are prescribing like benzodiazepines, things that can contraindicate?
Right, so you're right. I mean, there's a lot of prescribers, such as, I can just think, from the patients who come to my facility, well-meaning prescribers who are trying to get somebody, a medication that decreases anxiety, issues related to sleep, which could be due to multiple issues. They are also regulated to check the PMP just like everybody else. I don't know the statistics as to how often they do that. I'm going to take one more question and move on so that we have time for the end.
This may be later on in your slide, but one of the things that I've seen over time is that somebody that's been on opiates for chronic pain has, once the doctor suspects that there's abuse or addiction, misuse, whatever, strips them from that, and then they go from being prescribed out to using heroin.
Right, and that's part of why the education for providers is to learn about how do we manage patients with chronic pain, how do we taper them off of opioids safely, providing other modalities other than medications. And
So I heard you speak about that, but I was just wondering if there was some kind of ethical responsibility, because a lot of times I didn't hear the follow-up of therapy, of acupuncture, mindfulness. It was, you misused, we're done.
right, and then there's the, you're right, like where patient abandonment, where they effectively, suddenly there's a whole panel of patients that is without a prescriber. So I think that is another ethical issue to look at too. You're right. So we're going to move on to the next section just so that we have time for questions at the end. So again, the opioid overdose epidemic, this is looking at it from the Virginia Department of Health, so their vital statistics from the Chief Medical Examiner's office. So, but these trends do reflect the national trend as well, but we're going to be looking more at kind of the trends and the numbers you can look at in the bottom. So up until about 2007 or so, the number one method of a natural death, as we used to learn, I would say a couple decades ago, was that was due to motor vehicle accident-related deaths. So as you can see over time, it trended down and plateaued, and it's now the number third method of unnatural cause of death. The second unnatural cause of death has remained the same as far as number two. It has risen a little bit, and that is gun-related deaths. So those are definitely things that we have to pay attention to. And what is quite alarming, again, is the opiate. It's not just opioids, but it is often contributed by opioids. So fatal drug overdoses from 2007, it crossed the line right around 2012 and 13 as we heard about with all those regulations related to regulating pain, managing pain, prescribing drugs to get rid of pain. And as that increased, then you could see that fatal drug overdoses actually at least peaked in the Commonwealth in 2017. When I communicated with the Chief Medical Examiner's office, they're still waiting for the end of the first quarter to end before they can finalize 2018. So once they do, their projection is that it either plateaued, which in our case is actually good news, rather than continuing to escalate. It would be great if we start to turn the tide the other way as far as the fatal drug overdoses in general. So this is, again, a pictorial. If you look at the trends, this is almost the same line compared to the other one, but it's different because this is all drugs related to fatal drug overdoses. And then if we move on to all opioids, you can see that because opioids contribute to about 2/3 of fatal drug overdoses, the line looks about the same. And if we switch gears to opioids from a different perspective, and this kind of gets at what some of you have been concerned about, is like, we have this wicked problem of we're trying to control the prescribing of opioids, but then like with the law of supply and demand, where do the people go if they have an addiction? They're going to look for something that's going to be like opioids. And one thing I don't talk about in this lecture is specifically is kratom, is another substance that people have been seeking and using as they've been coming off of opioids or using it and getting addicted to kratom itself, which is opioid-like. So as far as the trends that you see is that with all opioids, that has continued to escalate. And then you can see that we're trying to control the prescription pharmaceutical opioids, but then there's an escalation in fentanyl and or heroin use, which does correlate with the increase in the fatal drug overdose epidemic. So let's take a look at what addiction is. I think that we should think about that because a lot of what's going on doesn't always make sense, and addiction doesn't always make sense. It occurs when a person cannot control their impulse to use a substance, so that could be alcohol, any substance, even when there are severe negative consequences. And behavioral changes are accompanied by changes in the brain, so we do think of it as a brain disease. So it changes the function, especially as it relates to reward, natural inhibition. So the frontal part of the brain, as far as stop, no go, stop, think again, first thought wrong, that part of it becomes dissociated so that they're no longer to make rational decisions based on the fact that the addiction is taken over. So based on the American Society of Addiction Medicine, again, addiction is a primary chronic disease of the brain. It affects rewards, motivation, memory, related circuitries, can lead to dysfunction of not only biological, psychological, social, but also spiritual manifestations. And that's something that often is neglected or left out because in the DSM, which is the Diagnostic Statistical Manual, there's a huge focus on pathology. There isn't very much of a focus on recovery if you look through the manual yourself. If you look at the pathology, it is related to the reward system, taking over the dopamine rewards pathway as one of the theories as far as how addiction works. It has been proven in research studies too by NIDA. So as far as these are some of the criteria for addiction based on ASAM, is the inability to stop using or abstain, impairment of behavioral control, which often affects not just the substance use, but just everything around them, including themselves. So cravings, that certainly is a huge part of urges, desires, repeated use, and then diminished insight despite the fact that all these negative consequences are going on, but they have either lack of insight or a minimization of what's occurring around them. Dysfunctional emotional response, lability, things that might look like bipolar. They may look like they're having, they certainly will have mood episodes, whether that be severe major depressive episodes, suicidal ideation, and other things, as far as even psychosis, which oftentimes could be secondary to the substance use. A cycle of relapse and remission, so unless it's treated, it will be progressive in nature, can lead to disability and or death, and requires not only treatment in the initial setting, but continued engagement for recovery so that they can continue to live a good life of recovery. So if you look at the DSM, this is a little bit cluttered, but the reason why I use it is for those of us who, I'm quite familiar with the DSM-4 TR, and then when we went into DSM-5, we had to kind of think about things a little bit differently. So for DSM-4, we're looking at things from the dichotomy of a substance abuse, substance dependence. So there were effectively 1, 2, 3, 4 criteria, and then we had these other criteria here for dependency. So they combined it in DSM-5 so that it became more of a spectrum of mild, moderate, severe substance use disorders. And they chose to get rid of the legal problems because, again, depending on which state you're in, marijuana might be legal in Colorado, but it's not legal in the Commonwealth of Virginia. Regardless, somebody could still be under the influence of marijuana and be operating a vehicle, be physically hazardous use of a substance such as any substance. So they chose to get rid of that one, and they added cravings to the spectrum so that there's 11 criteria. If you look at the 11 criteria, if somebody has 2 to 3 symptoms, that's in the mild, 4 to 5 is moderate, 6 or more is severe. And typically, if we want to try to translate it, again, the crosswalking to ICD-10 and to DSM-4-TR is imperfect, but generally anybody in the moderate to severe category typically is in the dependency category and has what looks more like addiction. So as far as management of addiction, there's kind of big picture things. Is one, we need to identify it, we need to screen for it, we need to intervene, and there's different ways to intervene, which we'll talk about. Certainly for some people, you're able to do the assessment yourself. Other times you may need to refer somebody for a formal evaluation. Maybe need to refer them for detox if indicated, such as coming off of alcohol, opioids, sedatives, other substances, barbiturates such as. And then getting treatment. So just identifying and diagnosing itself is not enough. We have to treat the problem and continue to provide care for it, monitor it, and provide accountability. And a lot of times people ask about, so why do we do urine drug screens? Well, why do we do blood sugar screenings for people with diabetes? It's because we're trying to monitor their status and see how they're doing. So lifestyle modifications. So that this is, again, management of a chronic disease. So if we think about addiction as a chronic medical condition that's similar to diabetes, chronic heart failure, is that we have to make some of our own behavioral changes, which again is a huge part of where us as providers can play a role in, is facilitating that. Monitoring, whether that be drug screening, other measurements for other medical conditions, providing psychosocial treatments, which is huge, as we learn in Project Match, things such as motivation-enhanced therapy, cognitive behavioral therapy, 12-step facilitated therapy. They play a huge role in patients getting sober and staying sober. Medicines can be a part of the puzzle. Relapse prevention and mutual support groups, which includes things such as AA, NA, Smart Recovery, Celebrate Recovery, things along that lines. So what about NA? So according to Mr. White and Dr. Galanter, and Galanter, he's at NYU, a huge supporter of not only patients who are in recovery, but also he does a lot of research related to people who are going to meetings, 12-step meetings. So there seems to be a paucity of attention to the benefits of Narcotics Anonymous in the current public, professional, and public policy responses, despite the fact that if you look back into the 1950s, and I didn't go back that far in my timeline, is that there was almost like an abandonment of patients who were having addiction issues. They didn't really fit into the AA community because AA, with the single purpose of people who were there to stop drinking, desire to stop drinking, that sometimes they didn't feel like they belonged because they were there to stop using other substances. So the community of NA or Narcotics Anonymous were there to support them. There was also the issue of like, how can people legally prescribe medications to treat an addiction such as opiates, because there was the Harrison Act, there's a number of things that got put in place to try to control things. On the other hand, it made it harder at times for healthcare providers to actually treat the addiction itself. So NA has been around for a long time. I'll get to you in a moment. So the 12-step recovery has been validated in a number of research studies by the National Institute on Drug Abuse, as well as the National Institute on Alcohol Abuse and Alcoholism, so NIAAA, so that it's effective, it's accessible, inexpensive, and it actually does enhance cognitive and behavioral changes that are important for recovery. You still have a question there, sir?
Yeah, I just had wanted to, if you would comment on that, under what about Narcotics Anonymous, the first thing, the paucity of attention to Narcotics Anonymous in current public, professional, and policy responses to rising opioid addiction. I guess paucity is the
lack
not
of.
very many.
You're right. Not a lot of attention has been paid to it. Yes, sir. Yeah. So and that'll be highlighted with the strategies that we're going to look at. That if you look at the kind of government recommendations, they often don't pay a lot of attention to that. Sure. So medications for relapse prevention. I like to use that word because it's all about preventing relapse. It's not just about do they have cravings right now. Because oftentimes the patient will say, well, I don't have any cravings. Well, what about if you went back to the same people, places, and things? Will you have cravings then? Well, probably yes. So FDA-approved medications, they are approved for tobacco use disorder, alcohol use disorder, and opiate use disorder. Currently, there's a lot of things being investigated, but nothing that's FDA-approved for stimulants, cocaine, sedatives, marijuana, hallucinogens, or designer drugs. So we're going to focus on the Food and Drug Administration approved ones. So for nicotine dependence, which we're a tobacco-free campus, kind of a wicked problem to itself. People can use all sorts of devices, whether it be vape devices, electronic cigarettes. People go off campus. It's so hard to control. But we do our best because we have well-meaning intentions for our patients here. So nicotine replacement therapy can include all different sorts of formulations such as patch, lozenge, gum, nasal spray, inhalers. The fast-acting ones we tend to avoid here just because they can actually get a bit of an intoxicating feeling if they use a lot of it over a short period of time. But they are used, and some people can use it safely, but not everybody. Bupropion SR, which comes in the formulation of Zyban and Wellbutrin, those are for different indications, but just the generic form can be used to help somebody stop using tobacco. And varenicline, which is commonly known as Chantix. I'm going to go through other categories. So for alcohol dependence, there's 3 FDA-approved categories of medications. So disulfiram, which often is known as Antabuse, that's the one that if somebody drank on top of using the medication, they often will get sick, start throwing up, and have other adverse consequences. Acamprosate, which is a medication that's supposed to try to balance the GABA, the GABA receptors as well as the glutamate receptors related to alcohol withdrawal. And the naltrexone, which is interestingly, is also indicated for opioid dependence, but they studied it in animal models as well as in humans. It was studied in Project Combine, which you can look up. It was done by NIAAA. So it's definitely an effective form of treatment for decreasing binge drinking as well as helping people to stay sober. It comes in an oral form as well as an injectable form. So we switch gears to the opiate dependencies. So oftentimes, people like to use the word MAT, which if you think about it, medication-assisted treatment is effectively what we do with nicotine dependence. We do that with alcohol dependence. If you go up into SAMHSA, the Substance Abuse Mental Health Services Administration, they refer to all these medications as MAT. For whatever reasons, MAT has a huge stigma. Oftentimes, when people use the word MAT, they're thinking about methadone. So methadone is a full opioid agonist, and it's been used for many years now in regulated, licensed clinics, facilities. We have buprenorphine, which comes in the formulation of Suboxone, Subutex. So it's a partial opioid agonist to try to minimize cravings, as well as it can be used to treat acute opioid withdrawal, and also be used as medication-assisted treatment that goes beyond the acute withdrawal era or spectrum of symptoms. So then as far as naltrexone, so naltrexone is an opiate antagonist, which is a blocker. So the interesting thing about naltrexone is that not only does it block the effects of the opioids from working if somebody were to use it, but it also has been shown in some brain studies in the last year, which has been published, to also decrease cravings for opioids too. So it's not just a blocker by pharmacology, but can also be associated and correlated with decreased cravings for opioids. Maybe one part of it is that they know that they're on the medication, but the brain does change. So if we look at things from the big picture perspective, so the America's 8-step program for opiate addiction. So again, one thing that everybody's looking at is how do we save lives. So a lot of the focus is on decreasing mortality and then finding different ways to mitigate that. Treating, not just arresting. And if they are arrested, to still provide treatment while they're in whatever setting they're in, such as in drug court settings or whatnot. Funding treatment, which we'll talk some more about. Combating stigma. Enforcing mental health parity, which is a huge problem that despite the laws, that not all insurance providers may exactly adhere to these rules or laws. Teaching about pain management, which we've talked about. Starting young with prevention, as we have all these young kids who are being exposed. And then again, MAT being something that can be helpful, particularly for somebody who needs to be stabilized and to get treatment for addiction. So kind of, again, alluding to the President's Commission in Drug Addiction and Opioid Crisis. As we talked about earlier, there's really little to any mention about mutual help support groups in this. But we talk about investing in programs that are achievable, quantifiable. They want to know where their money is going and that people are not misusing it, so such as by the Office of National Drug Control Policy. They wanted to streamline funds to the states as block grants, and this actually has been working, such as in the Commonwealth of Virginia and other states, so that they don't just have these huge federal regulations on how to use the money, but it's based on the state's needs, community health centers. Again, establishing drug courts so that they can be supportive of people who need treatment, whether that be on a medication-assisted treatment or not. Naloxone, Narcan, having that available, training us, healthcare providers, actually going as far as penalizing insurers for not covering addiction treatment. And one of the things that the hospital systems, I presented this information to nurses, I presented this to physicians, is that decoupling this whole hospital performance scale surveys with the Centers for Medicare and Medicaid Services related to pain is huge, because the more that is coupled together, the more incentive it is for people to use the most effective treatment while they're inpatient to get rid of that pain, which oftentimes is opioids. So in the best case scenario is that we're managing their pain so that they are not suffering and that they can be productive and also be able to do what they need to do, but without necessarily the pain score. Some people, if you ask them, their baseline pain score has been 7 for the last 5 years. So to make it 0 is effectively trying to put them at a risk of overdose. You're trying to put it to 0 where they're comatose or asleep. So 10 steps federal government should take now to reverse the opioid addiction epidemic. This is based on the Journal of the American Medical Association. So the first 5 steps are related to preventing opioid addiction and overdoses. So again, providing surveillance, which includes things like the prescription monitoring program database, improving reporting of overdose fatalities, which could be done based on big data that could be found online. Promoting more cautious prescribing, which we've already talked about, not only for acute pain, but also for chronic pain, and perhaps changing the labeling so that pharmaceutical companies are not saying that this is a safe drug that you can use for chronic pain. Increasing insurance coverage as well for, again, emphasizing non-opioid and non-pharmacological management of pain. So the second part has to do with treatment and harm reduction concepts. So again, we're trying to interrupt the whole supply and chain issue, which unfortunately the supply chain is often related to people ordering drugs online, and people will manufacture it on their own, or they'll order it from across the world. So it is, again, a wicked problem to itself. Identifying possible addiction early and linking it to treatment before it progresses. We've already talked about MAT. Harm reduction, there's a lot of, I would say, sometimes debate as to what is safe and what's not. So one of the harm reduction strategies is to prevent people from getting HIV, hepatitis, and other infections that could kill them. So the concept is to try to minimize that, which would lead to death. And then ultra-high dosages of opioid analgesics, removing them from the market if at all possible. And I'll get to questions once I get through this set of slides. So again, for funding for the opioid crisis, so we have the Department of Health and Human Services. They awarded more than $1 billion in grants. That was at pretty much the 3rd to 4th quarter of 2018 last year. So the good news is that money is coming out. It's actually not as money as they were funneling into when we were dealing with the AIDS epidemic. On the other hand, this is something, something better than nothing. So as far as for $900 and some million going straight into supporting states' treatment and prevention services, over $300 million going to community health centers, and almost $200 million going into conducting research. So as far as research goes, I think one of the things that we can pay attention to now, but also in the future, is the impact of artificial intelligence and how that might be helpful as well as potentially harmful. But as far as looking for signs of opiate drug overdose epidemic stuff related to fatal drug overdoses, really. So one of the studies they did in the Scientific American related to other academic universities was that they were looking at geotagged tweets. So then just by identifying these nicknames that they give for these drugs, drug handles, they could pinpoint clusters of opiate problems more readily than waiting for the National Survey on Drug Usage and Health to come out, which is typically towards the end of the year when everything has already happened. So it's a little bit too late by then. So it's just to empower people who know how to use social media in a way in order to look at epidemiological data. And as we start to switch gears, we want to look at what sort of innovative engagement strategies there are for trying to keep people not only in treatment but not turning them away from treatment. So community care coordinators, oftentimes these are either licensed or non-licensed healthcare providers, telephonic recovery coaching, digital apps that the patient or person or client can use to maybe steer them away from people, places, and things, so that there's like a GPS-related way of driving them a different direction away from where they used to use substances, as well as using apps to help them find meetings or to get help in whatever way that is. So wanted just to emphasize that our purpose is to attract people to care, not turn them away, develop trust, form partnerships, and support long-term recovery. So this is going to be right at our break point for questions before you guys go off and take a little break before we move on. So I have somebody back there.
Talking about the verification that started with opioid addiction, starting young. How young did you start? Did they start? Is there any kind of programs in the schools?
I would have to research like exactly what what programs are currently in place. Kind of reflecting back on what I've seen. So one of the things that they do with monitoring the future, which is again a survey they do on people that are in elementary, middle, high schoolers, is looking at the trends of when they first used any substance and their patterns over time. So I suppose that based on that data, they can also start to target education prevention programs that can help people who are younger. Starting young could also be, there are some newer studies with, again, brain imaging studies, which are not quite at the point of clinical use, but looking at people who are maybe susceptible, either based on family history, biological history, but also maybe based on their brain scans as to like when should they be, again, minimize their exposure to substances that are addictive early on. So I'll take one more question. Yes?
Can you comment on the use of Subutex for pain treatment?
So Subutex, so in the Virginia Board of Medicine regulation, Subutex is very tightly regulated. So that's the monoproduct of just buprenorphine by itself. So Subutex can be used in Virginia for the treatment of opiate addiction. It has to be, effectively, there has to be good reason to use Subutex by itself without the naloxone component. And if that is approved, then somebody can use it for the treatment of opiate addiction. Typically, there has to be exceptions in order to use it for other things such as chronic pain. Although, I would have to go back into look at the details. But what the Board of Medicine is encouraging is for people to use the combined version of buprenorphine with naloxone that has a lower diversion rate. If somebody tried to inject that, it might mitigate some of the not only the overdose risk, but also getting intoxicated risk. So the actual pill value of Subutex, they come in strips or films, but just buprenorphine on its own tends to be, they have a higher market value on the streets, so people like it more than just the Suboxone by itself. So it's a lot of good reasons that the Board of Medicine has stepped into that. But management of chronic pain is kind of a lecture to itself. So I'd like to give you guys a break, and if you'd like to come up, you can ask me the question you had. Yeah, so I think that your slides, I'm actually going to take a peek at Patty Cranford's here. Thank you. It's going to have a lot of information, which is unfortunately my wife gave me the comment one time that if it's that small that an ant can't even read it, why did she even print it out? So I apologize for the size of it, but it's more informational. You can go online. A lot of these slides are based on things that are accessible online. So we're not going to focus too much time on every single slide from here on because you guys have already been participating from a lecture standpoint. So the purpose of the next section is to really have a case discussion so that we can have a dialogue about how can we work together as a team to solve the opiate crisis. So, all right, so this is a case discussion. I kind of made it up on the fly, so it's kind of one of the cool things that we get to do for case discussions is that we kind of conglomerate and compile different cases that I've seen over time and kind of make up a fictional character named Bob. I was going to call him Bill because kind of after Bill Farley, who's, again, Dr. Farley. Do any of you know like why we're named the Farley Center? No idea. Okay, so well, this is good then. So William J. Farley, so he's a physician who unfortunately is no longer alive. So he worked as an anesthesiologist during his time, and he actually stopped working as an anesthesiologist because he got into trouble with his addiction. So as a result of his addiction, he got into recovery, and then part of his passion was to help patients get into recovery themselves, as well as helping healthcare providers. So William J. Farley is actually named, the William J. Farley Center is named after Dr. Bill Farley. So for those of you who've been coming to the Williamsburg Place Lecture Series all these years. So I was going to, and then Dr. Bob and Bill, if you guys know anything about AA, they work together. So as far as Bob, so he's a 55-year-old man with chronic back pain and depression. So he comes into your office complaining of, quote, not having energy to do anything at all. So you happen to have either consent or maybe his spouse is with him at the visit, that she's concerned that he's not himself anymore. He's been missing work, not interested in spending time with the family like he used to. So this is just a very, again, general chief complaint of a person who's coming into your office for help. So what sort of questions would you want to ask Bob and or his family, that being his spouse, any collaterals, so that being biologically, psychologically, social, and spiritual? Can you guys just maybe raise your hand or throw out some questions of what would you want to know if you had a client who was coming into your office today? Yes.
First time?
Oh, go ahead, please.
Is this the first time?
Is this, yeah, this will be a first-time visit. Yeah, so we've never seen this person before, and you had an idea? So are there any current medical issues that are being treated? How long have you been feeling this way with not having any energy at all? In the very back there.
What pain level you currently experience?
What is your pain level? And I think that that's a very good question, even though in the beginning I emphasized that it's not a vital sign, but it is a subjective report of how they feel, because pain is an experience. So it's not just the acute pain, but the chronic pain too. In the back there.
What in your lifestyle has changed recently?
Yeah, what has changed in your lifestyle recently, which is a nice broad question. In the back again. Has there been any trauma? Yes.
Medical history.
Yes, a full medical history. Yes.
Describe what his depression is, what are the symptoms of his depression?
Yes, so be very specific. It's not just accepting the word depressed is not enough, but finding the symptoms of depression. So I think you guys have great ideas. Yes, Rita? Family history, which is huge for biological and family dynamics. Any other ideas or suggestions?
Somebody already said medication.
I mean, they said medical history, but oftentimes medications may not be, quote, part of the medical history. So we do need to ask specifically what medicines. They may be taking supplements. They may be taking things that they don't consider as medications. I think those are all good questions. Yes.
I try and find a hook for things that they used to like to do, and how they feel about those things now,
Yes.
and what might help them. Anything they could think of that would help them get on back on track.
Yes. So finding what they're passionate about, what they are invested in, that also oftentimes can take a look at anhedonia if they no longer enjoy the things that they were passionate about. Yes, sir.
Yeah, I have a hearing problem, so I wasn't able to hear some of those things, but one thing, his age.
Oh, yes. So certainly, you're right. Like I gave the age of 55.
The fact that he is 55.
Oh, yes.
And maybe experiencing some things of just getting older.
Yes.
And also what his employment is.
That's a good question. Yeah, because I have no idea what he's missing work for. I think you're right about that time in his life. So just age, generational experiences. Yes.
Situational changes like divorce, marriage, a child getting married, loss of someone.
Right. This is again from his and his spouse perspective, but there may be a lot of other things going on. Yes.
I worked in workman's comp for 15 years.
Workman's comp.
This person asked if there'd been a trauma, but I'd probably ask when did you first started noticing your pain? Before it became chronic, it had to have been acute, I suppose. So
You're right.
The cause, if he had a notion as to the cause.
Right. It's helpful to identify if there was like an incident or event that might have either precipitated or been the start of the problem. Yes.
Question, but maybe to educate what depression is, because some people normalize it, they don't really know what it is. So because they don't know what it is, they think it's not significant, and then they don't get help for it, basically.
Right. Yeah. Oftentimes, men versus women, they present with depression in different ways. So his symptom of not having any energy to the wife might look like depression. So it could be either or both. Yes.
Have you ever had any suicide?
Yeah, so safety assessment. So suicidality, harm to self or others. Also risks for overdose, which that would be part of kind of initial screening or whatnot. Yes.
Has he tried to do anything so far to help himself, and has there been any success that he's felt he's sort of approximated feeling better?
Right. I think it's helpful if for me as an initial consultation or provider is to find out what interventions or what does he try to do, either on his own or with his family's help prior to coming in. Yes, sir?
How about his family history? If there have been particular things with his family, family of origin, if
Yes.
there have been particular kinds of illnesses or
Right.
repetitive things
Yeah,
to
so
affect his health.
yeah, that's a good point. I know the family history was mentioned earlier. I think family of origin is also important, particularly their developmental history, what impacted them as they were growing up, and which relates oftentimes to now as well. Yes.
Has it felt like that before, and if so, what did you do about it, and did it work? To kind of go back and say, okay, whatever skills you used before, it made you put it now, make you feel like that.
as far as what was effective and building on the strengths, looking at what didn't work and kind of problem solving together. Yeah, that's a great points. So I think we have enough questions. For those of you who've already read ahead, it's okay. But this is, again, just a hypothetical situation of this is a patient who's prescribed opioids. We are talking about the opioid crisis. And then they happen to also be, Bob is taking antidepressants. And in this case, more than one. He's also prescribed some sedatives. And I think we could say that, that's for anxiety, for insomnia, sleep issues. I'm not justifying or rationalizing that these are being prescribed appropriately, but this is just what he's on, all right? Psychologically, some of you asked about, what symptoms of depression has he had. He's been suffering from some form of what looks like major depressive disorder for years, since he was younger in age, even before he got on the substances that were prescribed. He has continued what looks like dysthymic disorder, almost like a double depression, as we sometimes call it. And then people asked about, what sort of changes in his life has occurred. He's still grieving the recent death of his mother. So those are some psychological issues that he's dealing with. Social aspects, he's been isolating himself at home. He doesn't really want to spend time with his family outside of home. In fact, spiritually, he used to be part of a men's support group, but he's stopped going, doesn't really want to get out of the house anymore either. So these are just some examples of things that are clinically relevant. As far as, so what about Bob? I think you guys, had a lot of excellent questions, which I'm not going to directly answer, but these are all things that we should be thinking about as part of assessing a patient who comes in with this particular presentation. So with SBIRT, screening, brief intervention, referral, and treatment. So for somebody who's coming to your door who you may not know a whole lot about, but they happen to be having these symptoms, and if you find out they also are on opioids, it is, I would say, somewhat of an obligation based on SBIRT that as either primary contact, primary provider, that we do our due diligence to screen for substance use disorders. So what they are recommending based on SAMHSA and CDC is that to screen for things such as tobacco use, which again, like if he's somebody who, I actually did not highlight this, but he's somebody who has not only obesity but sleep apnea. If he's smoking a lot of tobacco, contributing to something such as a chronic pulmonary disease, that's also going to cause problems with his energy and his mood. If he's drinking alcohol, how might that impact his other medications, his other physical conditions? How much is he drinking? Prescription medication use, so is he taking them at all? And if he is taking them, like how is he taking them? Drugs, when they use the word drugs, they're thinking of medicines that are not prescribed, so such as cocaine, illicit drugs that are not being actually prescribed to the patient, such as Bob. And then if something's anybody who's at risk based on these screening procedures, then it's really important to try to provide some form of a brief intervention. And if you yourself are not able to, then refer them out for help and making sure that they get the help they need through treatment. So any questions about that as it relates to the case that we have been brainstorming about? Nope? Oh, yes, Kathy.
A screening assessment you would recommend?
Sure. So we'll get to that now then. So as far as screening assessments, so for tobacco screening, these are a list of questions that can be helpful, particularly when you don't have a lot of time. So one of them is, have you ever smoked cigarettes or used other tobacco products? It actually doesn't include the language of vaping, electronic cigarettes, but you can include that. And then if yes, then on average, has it been within the last 30 days? How much has it been? And how long have you been smoking at that rate for? So those are good screening questions. For those of you who want to dig a little bit deeper or have the time to do so, this is a scale or test called a Fagerstrom tolerance test that might be helpful. This often looks at how addicted they are to the nicotine substance. It's like when they first wake up, how soon do they start using cigarettes or the tobacco product or nicotine product? Is it difficult to not use when they're on our campus where we're tobacco free? Which cigarette would you hate most to give up, that being early morning or any other? And then again, the frequency of use. So for people who identify as having alcoholism, drug addiction, typically they have a very high prevalence, up to 80 to 90% of them are co-using tobacco at the same time. So, and if they are using tobacco, oftentimes they're at least a pack a day to 2 pack a day users. And for people who use that much, we need to remember that not only are they detoxing from the other substances, but they're going to have nicotine withdrawal. So we need to be paying attention to treatment of their nicotine withdrawal and how do we try to keep them sober from tobacco at the same time. So then, how many of you know what a standard drink is? Like when you ask a patient what a standard drink, could you describe for me how you would elucidate that when you're with a patient? Or just like, what do you ask? Just a question if somebody's...
I ask how many drinks per day, what kind of beverage, quantities.
Yes. Yeah, I think that's great.
Idea of is it 5 drinks of 5 beers, 5 shots?
Yes.
Combination of the two.
So that's excellent. Sometimes a patient's concept of a drink is very different. So standard drink could be they've had one drink the whole day because they kept on filling it and it never ended. Or it could be much larger than a standard drink of what's calculated by NIAAA as 12 to 14 grams or 0.5 to 0.6 ounces of pure alcohol. So I think that your question of asking them specifically what type of alcohol is very important because there is going to be a dilutional effect of beer, although there's different types of beer, versus like spirits. Different size, yes. So yeah, so everything can play a role, including, so we're talking about volume as well as percent of alcohol. So you're right. So just keep that in mind when we're asking about standard drinks, is that the patient's perception may not be the same as ours. So again, this is assuming that we've kind of agreed on what is a standard drink. So for physically hazardous use of alcohol, some of the screening questions is based on for a typical male, again, this is not going to be for every male, but for people who are either not in the older adult range, but for a male that, let's say, less than 60 some years old, are they drinking 5 or more per occasion? So 5 or more is considered binge drinking, or are they using 14 or more per week? For a woman, if they're drinking 4 or more per occasion, or let's say more than 7 a week, that's also of concern. The per occasion is typically used as a marker for binge drinking. So again, this is from the National Highway Traffic Safety Administration. So we first look at men, and if you kind of, well, I'll just do this little switch to women, you can see the colors change, but we're still looking at the same numbers. So the concept is that based on an average, again, this is not all patients because patients are individualized, but if based on their body weight and the number of drinks that they had within the first hour, are they going to be possibly under the influence, impaired, or legally intoxicated? So again, every state's different based on the legal limit. But let's say there's a patient who comes to me who's in the 180-pound range. They're justifying that their BAC was 0.21 within the first hour or 2 of drinking. The reason why they were that high after having only 2 drinks was because they were dehydrated, they weren't eating and not drinking fluids. I mean, I definitely will question that because he's like within that 10-drink range. Even despite tolerance, I would not expect him to have gone up to 0.2 with just 1 or 2 drinks, if we're on the same page as far as within that first hour. And then as far as for women, because the free water of what's in humans is different between women and men, so average is that oftentimes the numbers are lower within that first hour before they might be impaired or legally intoxicated. So again, these are just numbers or ranges to go by. So for alcohol screening, Kathy was asking, what would be something I would recommend? So if you had to choose a tool, one of the most research-validated tools out there is the audit. So that's related to alcohol use disorders. So as far as if you don't have time to do a full audit, because it takes time, you can at least ask them, have they been binge drinking recently, particularly within the last couple of months or within the last year? Have you ever thought that you might have a problem with alcohol? Has anybody ever been injured as a result of your drinking or yourself? And then if daily use, have you ever had any withdrawal symptoms? So for some people, they might think of it as waking up with the shakes, tremors, waking up with nausea, vomiting in the mornings before they've had their first drink, the eye opener. So then without going through all 10 questions, you have this to refer to. Again, this is the Alcohol Use Disorders Identification Test. And based on the answers and the scoring, you can identify people who are at physical risk versus harmful use and dependence. So either simple advice focused on reduction of hazardous drinking as far as you know, or brief counseling and monitoring versus further diagnostic evaluation with a referral for treatment for alcohol use disorder. So these are, again, a spectrum of what you could do for a patient with alcohol use problems.
Score if there are 10 questions. How do you get scored?
Yeah, so for each question, you'll have to go online. So you could actually enter it onto, they have a calculator. So not everything's 1 point. Yeah, so they add up based on the, yeah, I don't want to make up all the numbers, but you can go online to the calculator. All right, so then for prescription medication use, so again, since we're talking about the fatal drug overdose epidemic, which includes not only opioids, but sedatives and other narcotics, is that, have you ever taken something that was not prescribed for you or in a way that was not prescribed? So then if yes, then you want to continue to ask more questions. So for Bob, you may want to ask him, even though he's, a working professional who's been going to, let's say, to a spiritual, let's say, church, you may not think of asking him, have you been using cocaine lately or any illicit substances? But it's actually not uncommon for somebody who's in that age range to be using other substances. So don't forget that he might be somebody who's using something like LSD that he was using years ago, stimulants, ecstasy. So it's important to think about those questions. There is a formal survey, but again, if you don't have time, just asking, have you been using anything like that in the past 3 months? How much are you using? When was the last use? And then if you use any drugs where you might have put yourself at risk for infections, then it's really important to get the physician or healthcare provider involved with looking for any signs of infection. For those of you who's less familiar with how to quantitate cocaine, heroin, and marijuana, this is a, quote, pocket guide that was for ESPERD based on the West Virginia Medical Professionals Health Program. So it's just different lingos of how to quantitate it. Again, it's an imperfect system because more and more now we see that opiates are laced with fentanyl and other substances that dramatically increases the risk of fatal drug overdose. For those of you who like to use a, again, validated tool, this is the drug abuse screening test. It has 10 questions. A lot of it mirrors the audit, and then based on these questions, you can score the patient based on, are they not at risk? Do they need further monitoring, further investigation, or assessment? So for those of you who work with younger adults or adolescents or even children, so that's in the category where I work with adults, and children only get involved if they happen to be related to the patient that I'm taking care of, or my own children. So these are actually really good questions. Because a lot of times, these are supposed to kind of engage the adolescent, but also make it so that they don't feel like they're going to get into trouble. So one of the questions you can ask is, have you ever ridden in a car driven by someone else, or even by yourself, I guess, that had been using substances? So you try to kind of disarm them a little bit. Have you ever used anything to relax or to feel better or to fit in, to not be alone? And also, do you ever forget things that you use, such as related to blacking out, memory loss? Do your family or friends tell you that you should cut down or stop using substances? And then have you ever gotten into any form of trouble, whether that could be academics or other issues related to substance use? So that just is one mnemonic for engaging adolescents. So for brief intervention, I know many of you are aware of what that is, but just as a quick summary is that you want to bring up the subject. We don't want to avoid it. Provide feedback for the person that we're with. Assess, let's say if Bob is saying that I'm using more opioids than I'm supposed to. I'm consistently running out of my opioids early. I'm not going back to get the refills early, but when I run out of it early, I'm actually going through severe opiate withdrawal. And that's part of why I just don't want to get out of the house, because I'm having nausea, vomiting, diarrhea. I feel even more depressed when I'm going through opiate withdrawal, and I don't know what to do. So you try to assess their readiness to change as to what is it that's going on that can help them to decrease his use of opioids in a way that's safe, and to engage also their other providers who's prescribing the opioids for them. Enhancing his motivation, negotiating and advising with a specific goal and plan that's achievable, that you follow up on or have somebody else follow up on, and then making sure that they show up to see what happens for the outcome. And then again, being comfortable with referring to treatment, because not everybody's able to do everything. For those of you who do counseling, therapy, the ORS technique is, again, just to ask open-ended questions like you guys did early on with this case discussion, to affirm the positives, to try to provide reflective listening so that we're not feeling like we're interrogating them the whole time, and providing summary statements to show that we are listening and trying to empathize and validate what they're saying. For, again, motivation-enhanced therapy, a lot of this is related to collaboration, a partnership, evoking their perceptions, so being client-centered, patient-centered, providing them with some form of autonomy, because a lot of times in the medical model, we're constantly, quote, treating disease, we're often telling them what to do, but often in our treatment provider setting, we need to be working with the patient on recovery. The REACH principle, again, goes into with rolling with the resistance, because not every person who comes in the door, like Bob may say that, you know, I still want to be on these opiates, and I don't want you to talk to my healthcare provider. I'm not going to consent for you to do so, because I feel like I still need them, and I'm afraid, you know, kind of based on fear, is that if you talk to them, I'm going to lose my opioids, and then I'm going to be in worse pain. So it's about how do we work with this person, providing empathy, avoiding argumentation so that we're not, you know, certainly there's going to be some debates, but it's about how to work together. Develop discrepancy on things that, you know, Bob really enjoys being with his men's group. He really enjoys going out with his family. So what can we do to make that happen? And supporting self-efficacy that is, you know, beyond just the treatment team providers, because we're not going to be with them 24 hours a day. So anybody use the readiness ruler? Something that some head nodding. So the readiness ruler in itself, the concept is very simple, but sometimes it's really helped to have a visualization for our client or patient, because it does work. That's why. So for the readiness ruler, you look at how important is it for them to make that change. So let's say if Bob says, you know, well, I think it is really important because my wife is, you know, not happy. I'm not happy when she's not happy. So let's say it's like 8 or 9. And then confidence, he's not so sure. He may be 4 or 5. He's not so sure that he's able to do it. How ready is he? Well, maybe he's like right in the middle, 6 to 7. So we kind of work with all these different levels of change, and how do we get them to make that change. For him, I would say that he's beyond pre-contemplation. That would be effectively when he's not ready for change at all. And then contemplating it, he's definitely in that phase. He's not quite at the preparation phase yet, and that's where we can help him and facilitate that with his, you know, family support, taking action and maintaining the change that's going to be sustainable and helpful. So for some people, it's helpful, again, to have a balance sheet. So unfortunately, this sounds a lot like accounting or finance. So for balancing, how does the changed behaviors have pros and cons, and how does a continued behavior have its pros and cons? So this is looking at it from the tobacco kind of perspective. So let's say if he was using a pack a day of tobacco on top of everything else, then he might breathe better if he were to cut back his use of tobacco. On the other hand, he may start noticing not only opiate withdrawal, but also nicotine cravings too. So what do we do about that? If he continues his use of tobacco, even though he's going to work less, when he does go to work, he actually kind of hangs out with the people who are smoking. So that's where he socializes in his limited setting. But then he smells like tobacco all the time, and it's going to worsen his lung disease, so that's not helpful. So one of the things that we can do for follow-up is, again, asking how did they do with their goals. I've had oftentimes, myself included, is that I'll have a patient come back to see me, and then I'm so worried about the acute crisis at hand is that I either don't make time, or I forget to follow up on the recommendations or the goals that the patient and client and I set the time before. So I think the patient actually, they feel invalidated when that happens. So even though we're trying to address the acute crisis, we also need to acknowledge that, you know, last time we discussed this plan, how did you do, and how's it working for you? So because they may have actually achieved some of those goals, and they may be very excited to share that with you. On the other hand, they may have another crisis that's, you know, come at hand within the last couple weeks. So the part about considering use of medications, certainly that's within our scope of practice. We've already talked about the wicked problem of, you know, more is not necessarily better. Polypharmacy can lead to a lot of problems. But if they truly need help with opiate addiction, and it's gotten to the level where it's out of your, you know, ability to help them, definitely refer them for treatment and allow a specialist to take a look at that. And certainly, don't forget that mutual support groups are there, and oftentimes they're free, they're accessible. So please use them as a way to help the person beyond just what you're doing and what the family's doing. I think this is kind of nice for those of us who are not as familiar with urine tox screens. So oftentimes, we're either given these results or told about these results when a patient comes to us. So let's say urine drug screens, there's different ways to do it. There's a point-of-care cups where it's a very quick immunoassay. There's also what's called instrumented immunoassays that are done in the lab setting with cutoff values. And then it could also be sent off to confirm for drugs that might look like another drug. So on immunoassays, sometimes, this is just for example, naltrexone, which is the opioid blocker, sits on the opioid receptor. So if you have a really quick point-of-care immunoassay, if you look at it quickly, it may look a lot like oxycodone. Well, maybe are they using oxycodone? I don't know. But they may be taking their naltrexone, because the naltrexone sits right on top of it. So on some of the immunoassays, they can cross-react, and that's where you want to send it off for confirmation. You can't just assume whatever's on the point of care is exactly what they're taking. If you look at a pure opiate screen, these are like the NIDA opiate screens. They test for morphine-derived products, kind of like from the natural opium products, but they may not detect synthetic opioids such as fentanyl, which is a very special test to itself. Amphetamine screens, somebody might be using a whole lot of Sudafed as a way to get high. Dextromethorphan, which is like Robitussin, DM, those sort of drugs, it's not going to be picked up on a amphetamine or stimulant screen. And even some of the benzo screens, they may miss drugs such as Xanax and Klonopin, just because it doesn't, their chemical structures are different enough that the benzo screen can look for things more like Ativan or lorazepam, but they may miss other substances. So these screens are, again, they're a screen. Just like if we're asking a question, it's like the beginning of figuring things out, and you have to confirm things from there. So for those of us who actually do deal with urine drug screens, maybe you work collaboratively like in an intensive outpatient program where you have to do drug screening. You want to write out, or you really do need to know what medicines they're on, because some of these medicines will cross-react with the drug screening. You want to equate the drug screen to a physical exam. So we're not testing them to quote because we're trying to get them into trouble. We're doing it because it's part of treatment. So it's a physical exam. That's part of why they get a drug screen. That's part of why if they're in IOP or at any level of treatment, typically drug screening can be part of the treatment reimbursement rate with either insurance or somehow, but not always. So you want to examine the patient carefully, because let's say if Bob, in his case, started going out to use heroin in order to treat his withdrawal symptoms from the pharmaceutical opioids, he might have some track marks on him, and you may not have thought that Bob, he's wearing long sleeves in the cold weather. Like why would he ever use IV heroin? Well, maybe because he was desperate. And then duplicating the test. So like if it's a test that doesn't make sense, you want to ask for help, whether that be from the laboratory toxicologist, the healthcare provider who's ordering the test, medical review officer. But sometimes retesting might be indicated for confirmation reasons. So again, don't be afraid to ask for help, because sometimes we do need to refer them out to a specific program, learning about what the resources are around you. So for Bob, if he really does have an opiate addiction, then learning about, does he need what level of care? Is it safe to do it outpatient? Does he need more intensive outpatient, partial hospitalization, residential treatment, inpatient medical, surgical, psychiatric hospitalization if he's having suicidal ideation as he's going through all these symptoms and life changes. So SAMHSA. So the one thing that I like about SAMHSA's definition of recovery is that it is focused on wellness. It's not just about disease. So it's a process of change to which individuals can improve their health, wellness, live a self-directed life, but also asking for help, striving to reach their full potential of where they are. And in their health, it's not only physical, but emotional, and we talked about biological, psychological, social, spiritual. It's in their home environment, because not everybody has a safe place to go back to. So for some of our patients or clients, we need to make sure that they have a safe place that's stable. Having purpose or meaning in their life, which I think one of you talked about, what is it that they really are passionate about? What is it that they enjoy? Because if they don't have meaning in life, then it's not going to really be meaningful for them to wake up the next morning to do anything at all. And one of the things that's great about SAMHSA's definition of recovery is it's about community, is not being alone. It's about building relationships with your network, and also with friendship, love, and hope, which are words that we don't find in the DSM. Is again, diagnostic statistical manual, very laden with words related to pathology. So we're talking about love and hope. So I was going to close with Dr. Murthy. He was our 19th Surgeon General of the U.S. So he wanted to address this opiate drug overdose epidemic, saying that we must stop treating addiction as a moral failing and start seeing it for what it is, a chronic disease that must be treated with urgency and compassion. So I'll stop here for questions. Okay, thank you. So we have about 5 minutes, is that right? So any questions before we end for the day? Yes?
I work with seniors, and I'm not in treatment or anything, but I come across people that are, a lot of them are on oxycodone, and because of their age, they feel like they need this pain relief, and I don't know what kind of other options there are
for seniors and older adults. Yes, yeah, that is hard. That is part of why a lot of times people go into the specialty of geriatrics or geropsychiatry, is that there are so many things that, let's say as a medical professional, that's outside of my scope of practice for seniors. So chronic pain management, it's difficult because they often have already been prescribed it for a period of time. And then the prescribers have to make a good, make their best decision with the senior citizen as to what to do as far as the prescriptions. It often is safe and also doable to taper off the opioids gradually over time, but not to do it abruptly. Because the more abrupt and the more negative experience that they have with getting them off the opioids in a safe fashion so that you mitigate the risk of overdose, but also if they have a desire to come off the opioids and do other forms of treatment, then yeah, I think it's just working as a team as much as possible. Any other questions? All right, well, thanks for your time and participation. Have a good day.